This was my first critical limb ischemia case as an attending a couple years ago. 65-year-old woman, some comorbidities, had known PAD. She'd had a few toe amputations on both sides, and she'd had a history of a right fem pop bypass, the distant past, at another institution. So she went to her podiatrist for some necrosis in her left fourth and fifth toes, as well as also on her left heel, and she underwent amputation of the left fourth and fifth toes a few months prior, and the bases of the toes were not healing well. So her podiatrist sent her to me for vascular evaluation, and she did have some Doppler signals bilaterally, but they were pretty weak on the left. So I ordered PVRs, and this is what her initial PVRs look like. I don't know if you can read this well, but about 0.4 on the left, 0.8, 0.9 on the right, so doing okay on the right. But I felt she warranted an angiogram. So here's the initial angiogram. Some aortic disease, iliacs didn't look too bad, and she does have some bilateral common femoral disease, mild, moderate. But this is the main problem here, was her SFA was occluded on the left. She did have some collateral flow. She reconstituted her SFA distally, and then she subsequently occluded her pop, and then that reconstituted in the AT, and had one vessel runoff to the foot here. So she was getting poor inline flow, and her collateral flow here was not great, and her pedal arch was not robust either. So she's 65. She does have some comorbidities. I thought maybe bypass potentially an option, but I felt that with her comorbidities, she wasn't the most robust surgical candidate. I thought we'd try to do this endovascularly. So I used a wire and catheter technique. I used a stiff angle glide wire to get through SFA, and I used an angle glide catheter and got through it without a lot of difficulty. I did get subintimal for a good portion of the SFA, but re-entered kind of in that distal reconstitution of the SFA. And I actually did go through and verify that by IVUS, kind of getting a sense of where I was in the subintimal space, trying to determine the best therapy following my wiring. So then I used an 014 wire to kind of get through the popliteal into the AT. I used a Miracle Brothers 3. Went through without a lot of difficulty, but it did take a little bit of work and some time, but I did verify that I was in the true lumen of the AT distally. So then I just went through with a chocolate balloon, ballooned open the AT distally, dilated the SFA. Because I was subintimal for most of it, I did end up using overlapping Zilver PTX stents through most of the SFA down toward the knee joint, and had a reasonable result. I was pretty happy with my result. I had good flow to the foot. Her rest pain improved. Her Doppler signals were much stronger on the left foot at the end of the case. But when she went back to her room several hours later, she did get kind of an abrupt onset of left lower extremity pain, and she lost her Doppler signals in her left foot. So I quickly got repeat PVRs just to kind of get a sense of what I was dealing with before taking her back to the lab, which I thought was inevitable at that point. And she clearly had a proximal problem here. So I was concerned that the entire thing had shut down, which it had. So here's my repeat angiogram. You can see her entire SFA had shut down. And you see here in her common femoral, she does have a pretty severe complex dissection. So at that point, I felt, she's probably going to need her common femoral fixed. What's the best way to do that? Can I do this endovascularly? So while I was kind of thinking about options and getting one of my colleagues involved from vascular surgery, I did decide to go ahead and open this up. She was having rest pain. She had no real good signals in the leg or in the foot. So I was able to get an 035 wire through the dissection without a lot of difficulty. I felt confident I was true lumen all the way down. And I just took a 50 centimeter ECOS catheter and advanced it down past my stents where she had reconstitution in the AT, and I just ran low-dose TPA for several hours and had a beautiful result with that. As you guys can imagine, that use TPA in this acute setting, in arterial thrombus, it resolves relatively quickly. And so she had wonderful flow again, but the question is, what do I do with this, and how did it happen? If you look before my intervention, this is the common femoral here. You see some eccentric plaque. You see a branch come off here. This is at the end of my intervention. You see the plaque here. You see the same branch coming down here, but you do see some dye here in the common femoral, and you see that the width of my distal common femoral is not quite the same here. You're starting to see some narrowing of the lumen. And so you see signs of dissection here. This is my last shot during my case, and I did not appreciate that this was dissection next to this branch here. And I assume that was either caused by my proximal edge of the stent, or I had a sheath down here in the common femoral while I was working in the lower extremity, and I don't know if the sheath disrupted some plaque here that then caused an antegrade dissection. So this is what I'm left with. She's now got good flow into her foot, but she has this common femoral dissection. I don't know how many of you would have tried to address this endovascularly. I felt that if I tried to put a stent here in her common femoral, I would shut down her profunda. I felt that the dissection involved it. So I did contact my vascular surgery colleagues and asked if they could just repair her common femoral. They felt that with her new stent in the SFA, they would have difficulty with clamping and hemostasis, and they opted actually just to do a bypass of her entire leg. So they did a common femoral to tibial bypass. And she actually had a nice result. She got through the surgery without a lot of problem despite her comorbidities. They did do an enterectomy of the common femoral, but then they did bypass with a vein conduit. And she had very strong Doppler signals following that. And I still follow her to this day, and she still has a reasonable outcome with good pulses in the feet, good Doppler signals in the foot. So good result in the end. But I did learn a lot about, I'm a cardiologist. I scrutinize my coronary shots at the end of my case to make sure I don't have a wire perforation or a complication when I pull my wire out. In this case, I probably should have scrutinized my common femoral a little more after I took my sheath back and took my final shots. Thank you.